Hi everyone, thanks for all coming along to our webinar this evening. It's being given by Dr. June Lau in ST2 in Radiology on a very important topic for all of us. It's on trauma x-rays. Without any further ado, I'm just going to hand over to June to take away the rest of the session.
Thank you very much. So my name is June, and I'm currently working as an ST2 radiology reg in Manchester. And hopefully within this next hour, we'll be able to go through how I look at trauma x-rays. So because we only have an hour, I did a quick survey of some of the junior doctors that I knew, and we chose some of the images that we thought would give us the highest yield. So in this session, what I hope to do is go through a brief assessment structure. So a structure that I use for every single trauma x-ray that I assess. And then we'll use that structure to go through each of these in turn. So the cervical spine, the shoulder, and the ankle. So that's what I have planned, but obviously depending on what kind of time we have, we'll see how much we can do. And for the interest of time, if you have any questions, I'm obviously more than happy to answer them. But if you can jot them down for now and then ask them at the end, that would kind of make sure that we have the time to go through what we need and then answer the questions later. All right. So let's start off with our assessment structure. Now, I am hammering this home once again. In radiology, we have to make sure that our films are adequate. So that's the first and most important step. It's like checking for danger in BLS. You want to make sure that you have enough views to assess the joint or the injury. You want to make sure that actually the entirety of what you want to assess is included. There's no point having, missing the end of the finger if you want to make sure that the entire finger is not fractured. And then finally, make sure you check for previous imaging because something might be chronic and you're worrying over nothing. So once you're happy with adequacy, then you can move on to your approach. And in radiology, we love ABCs. So this is the same. You've got ABC to S to look at trauma x-rays. So A stands for alignment, B for bones, C for cartilage. And of course, where there's cartilage is often a joint space. And then 2S stands for soft tissues and special review areas. So for each of the x-rays we're going to look through, there are certain special review areas that we will touch upon. So let's start with A. You've got alignment, and it's quite self-explanatory. You want to make sure that all your bones are well aligned. Make sure that that is the case no matter how many joints you have, basically. And here you can see the third metatarsophalangeal joint is not well aligned, and it's been dislocated. Then you move on to B. So B is bones, and that's the majority of what we're going to be looking at in a trauma x-ray. And there are two ways you can assess the bones. First is by tracing the cortical outline. It's very simple. You take finger, a pen, whatever you have, and just trace the outline of each and every bone. And it should be nice and sharp. And if it's not, or you notice like, oh, there's a bit of a step or an irregularity, then interrogate that region further. And in this case, you can see in the fourth metacarpal, there is a fracture. This is also a very common fracture that you see, especially if people come in with a history of punching something, a person or a wall. And it's also ironically known as a boxer's fracture. Now, tracing the cortical outline is even more important when you want to think about pediatric x-rays. So here you've got a pediatric wrist, and you can see that the physis hasn't fused yet. The carpal bones are all tiny because they haven't fully ossified. Now, a lot of people are quite scared to look at pediatric x-rays because they look a bit odd. But if you just remember that pediatric bones are soft, they're elastic, they don't break like adult bones, I think, and you trace the cortical outline, you're going to spot most of the abnormalities. So if we trace this outline here, you can see, oh, there looks like there's a little bump. And if I magnify that, this line here shows what I'm looking at. And this is known as a buccal fracture, also a torus fracture. And if I can convince you, the trabecular pattern here has been disrupted as well. Which brings me on to the next way we look at bones, which is to look at the trabeculae and the texture. So we've got all these tiny, tiny little lines of stress along most bones, in fact, all bones. And while you're tracing the cortices, make sure you just look at the bones and make sure that these lines are all running in the right directions. There are no abnormal breaks along them as well. Now, when I talk about texture, obviously, I'm referring to cortical texture. So if you look at this foot here, which is belonging to a young lady who is a runner coming with foot pain, and the first x-ray doesn't show anything. Nice, smooth cortices. She goes home, keeps running on that foot, and then 3 weeks later she comes back because the pain is not better, and you can see an irregularity on the third metatarsal here. And this is a callus, and if you were to see this in real life, the texture is very fuzzy, and this is actually what a stress fracture would look like, really, really small micro stress fractures that you can't see initially, but you can see the reaction of. So the reason why the bone gets fuzzy and form a callus is due to the periosteum. So the periosteum is a little cling film that goes all over every bone, and it responds to any injury, any infection or inflammation. So sometimes you'll get x-rays or you request x-rays to look for osteomyelitis or for inflammatory arthritis, and this is what you're looking for, the texture of the cortex. So we're happy with A and B, then we can move on to C. So we're looking at our joint spaces. I know C stands for cartilage, but just remember it's the joint space. So a joint space can be narrowed or can be widened. Now, in the context of trauma, a narrow joint space is less concerning because it tends to occur more chronically. And I'm sure you've seen many osteoarthritic joints in your work, and they often appear with narrow joint spaces, bit of increased density or subchondral sclerosis, and maybe sometimes you even see some osteophyte formation. So this, if someone comes in and complains of toe pain, and you see this, and the joint space is a bit narrowed, you're not too concerned, especially if there's no fractures. But in the cases of this, so here you've correctly identified the distal radial fracture. But if you're not looking at the joint spaces, then you might miss something like this. If I can convince you this joint space here is much wider than this joint space here. And this is obviously more concerning because joint space widening is often caused by rupturing of ligaments. And in this case, yes, there's a rupture of ligament between these two carpal bones. Okay, so once you're happy with the size of your joint space, you need to think about what can be in your joint space. So there should be nothing. Basically, there should just be cartilage and a little bit of lubricating fluid. But in an injury, if you see little flecks of bone like this inside your joint space, then you need to be concerned that there's been a fracture somewhere and a fleck of bone has come off. So in this case here, you've got an AP view of an ankle, and this little bone fleck here is now within the joint space because it's come off your talus, the talar dome. And this is just a little anatomical illustration of that. Speaking of joint spaces, the other most common thing we can find in the context of trauma is obviously an effusion. So I found it quite difficult to identify effusions up until very recently. So if you just think about it, it's all about densities. So it's important to know where effusions can occur. For example, in the knee, you know they kind of happen in and around here. Perhaps if they're big, down here underneath, sort of inferior to the patella. But you have to understand density. So if we look out here, it's black. Black is air on an X-ray. Slightly less black, so that tends to be fat. Then you've got soft tissue, so you've got all your tendons here. That's kind of a medium gray. Then you've got your bone, and obviously the most dense thing on an X-ray is going to be metal. So if if you are looking in the region where you expect an effusion to be, and it looks the same density as soft tissue, then you can be quite confident that this is an effusion. All right, so we've done our A, B's, and C's, and then we can move on to 2S. So the first S is soft tissue. When you get an X-ray, obviously you're paying attention to the bones, but don't forget you've got soft tissue on there you have to be able to look at. In some cases, you interrogate the bone, you trace every single cortex, you can't find anything. Doesn't mean there isn't an injury, it just means you can't see it on this X-ray. In the case of soft tissue swelling, that's a good indication that something else is injured. Or in the very rare cases where you see a little nick in the bone or a line that you think is a fracture, but there's no soft tissue swelling next to it, then you can feel safer saying it's probably something more chronic or something more benign and not an acute fracture. So soft tissue is very important. I've only included this here because in the context of a C-spine, soft tissue doesn't only mean external soft tissue, but it also means internal soft tissue, especially this region here called the pre-vertebral soft tissue space. And with regards to special review areas, we will touch on those as we go along assessing each of these X-rays. And that's it. So that is the ABC2S that I use to look at most trauma X-rays. So we can begin by actually looking at some bones and some X-rays now. We'll start off with our cervical spine. And with each of these sections, what I'll do is I'll go through a recap of the anatomy. And then we'll start using the assessment structure to go through our X-ray. And then finally, there'll be some good cases for you guys to interact with. So I'm hoping that in the cases section, you guys can type your answers in the comment box and we can have a bit of a discussion. Right, so in a cervical spine X-ray, you get two views. You get your lateral view and your AP view. And I have to say, most of the assessment of the trauma is often done on the lateral view, although obviously if you've got something to see, you should look at it. So a brief, sorry about this, a brief recap of the anatomy. So looking at our lateral view, you've got your vertebral bodies. I often find C2 is the most, is the easiest vertebra to identify, and then you can count downwards. An adequate C-spine X-ray should allow you to visualize the top of T1. You've got your facet joints, so these give your C-spine the movement. Then you've got a portion called the pars interarticularis. Pars stands for bridge, and really it's just a connection between your superior and your inferior articulating facet. You've got the lamina, and so that's the little roof here around the spinal canal. And then your spinous process kind of comes off the tip of that roof. And you can see it very nicely highlighted here. On your AP view, you can see slightly less, but you can still see some things. You can see vertebral bodies, obviously. Just like how C2 was easier to see on the lateral view, on an AP view, I find it easier to find C7, T1 first. And the way I do that is by finding this horizontal diamond sign. You'll find that C7 transverse processes point down, and then T1 points up. So if you find this diamond, you know you're at C7, T1, and you can count upwards. Just bear in mind that some of the upper cervical bodies might be hidden behind the chin, and that's varied by how high or low your patient's head is tilted. You can see pedicles, so these are little round things over here that you can see. These are the pedicles of your vertebra. And of course, you can see spinous processes. Okay, so now that we're happy with our anatomy, we can start actually assessing this C-spine X-ray. We'll start off with A, and A is your alignment. Now in a C-spine, there are 4 lines that you need to know. And if you can remember these 4 lines, you're going to see most, if not all, of the C-spine fractures or dislocations and transections. So these are what they are. You've got your anterior vertebral line, your posterior vertebral line, so it's the front and the back of your vertebral bodies. You've got your spinal lamina line, and what that is remember the roof and the spine coming up the top, so it's that line where they all join, kind of like the Mercedes-Benz bit. And that's that line there. And then you've got your posterior spinal line, and that's just the line from all the little spinous processes all the way down, the tips of them. Now, I know these lines aren't straight, so you're not looking to make sure that they're straight. What you're looking to make sure is that they can continue down unbroken. If you start following down one and you notice that there's a step, then that's an indication that you should interrogate that region further. Once you're happy with your alignment, you then can move on to bones. So that means we start tracing around the vertebral body bones, but we also need to bear in mind that the vertebral bodies should be of the same height. Now, it's very uncommon to get a compression fracture in the C-spine because of the lack of axial loading. But if you keep in your mind that you just have to look at the heights, then you're going to notice any other traumatic fractures that can happen there as well. Then we look at the cartilage or the joint spaces. So there are 2 main joint spaces in your C-spine. You've got your disc spaces in between your vertebral bodies, but you also have your facet joints as well. So you want to make sure that these are all of the similar height. And if they're narrowed, no, not too concerned. It's quite common to get cervical spondyloarthropathy as we get older. But if they are widened and someone has sustained sort of flexion or extension injury, then that is concerning, because that could mean that you've almost torn your disc from your vertebra, and that's quite an unstable injury. Same goes for facet joints. They should all be the same height. And then we can move on to 2S. So I briefly mentioned soft tissue spaces in the C-spine, and this, I think, is a rarely known point, but it's good to remember your pre-vertebral soft tissue space limits. So from C1 to C3, your pre-vertebral soft tissue space, so this region between the front of your vertebra and the trachea, should be about 1/3 of the vertebral body width. Helpfully, C1 to C3, 1/3 is 1/3. And then from C4 onwards, it can be up to a whole vertebral body width. So here, where the stars are, it can be up to the whole width of the vertebral body. If it's less than that, not concerning. If it's more than that, then you need to consider why. In the context of infection or raised inflammatory markers, is this an abscess in your retropharynx? Or in the context of trauma, could the ligaments have ruptured and you've got a hematoma in that region? Of course, you've got a lateral view, and we've done a lot of the assessment on there, but you've also got an AP view, so you need to look at it and make sure that it looks all right as well. What you can assess on an AP view is your spinal alignment. So you've still got lines you can draw. Your spinous processes should form a line. The transverse processes should as well. You can assess vertebral body heights, but bear in mind if they look slightly squished, it could depend on the flexion and extension of someone's neck. And then of course you can assess disc spaces. So we've done ABC and 1S. The last S is our special review area, and that has to do with the top joint over here between C1 and C2. So this here, I like to call the little coffee bean, is the anterior sort of arch of your C1 that's like a ring. Now there's a specific amount of space that should be between the dens or the odontoid peg of C2 and C1. If it's narrowed, can happen in osteoarthritis. If it's widened, then you need to think about whether or not there's subluxation or loosening or rupture of the ligament that holds them together. Because if you think about it, you've got a peg, you've got a ring, and if it's not articulating properly, your head is not going to be stable on that joint. So it's quite important. Once you're happy with everything else, make sure you look at this area and you're happy with that articulation. And there's an example of the predental space. And that's it. So that is how you look at a C-spine with the ABC2S method. Now, what I'm hoping to do is go on to some cases. So what I'll do is I'll show the pictures, and then if you can kindly type your answers in the question box, then we can go through them.
Someone said dislocation at C4. And then someone said there is no anterior and posterior alignment.
That's great. So, so ignore the fancy name, but you're exactly right. So you've got some sort of dislocation between C3 and 4. Facet joints are widened. There's anterior and posterior line disruption. And if you look here, there's the C4 vertebra is not intact anymore, basically. So you've got a fracture. And this is a fracture that you can see in whiplash injuries when you have severe hyperextension followed by severe and high force hyperflexion. And that it's almost like this bit of C3 has gone straight into C4 and fractured it. But well done, you using the lines properly. We can move on to our next case.
So somebody said C3 fracture.
Close. It is a fracture. I think this is what you're looking at, isn't it? But it's not C3. Have another go.
Somebody said compression fracture at C2-3, posterior line not aligned at C3, no laminar alignment.
Okay, so that's good that you're trying to, I suppose, articulate it using the alignments. So here's your fracture, and this is C2. So this is your dens here. You've got the bigger spinous process is also of C2. So you've got a flexion, again, another sort of hyperflexion fracture of C2. And your posterior alignment is still maintained. Your spinal lamina line is here. And it's tricky to look at it here. I will appreciate that, but there's no step. So here I would still say it's maintained. And then if you look at your spinal lamina line, the spinous process line here, that's not got a step in it either. So as long as you can draw some, this is a very straight cervical spine. Usually you'd get some sort of lordosis, but in this case, if you can draw a line through it without disruptions, I would still say it's well aligned. So this is a C2 flexion teardrop fracture. Well done for giving it a go though, guys. And here is just that example on CT, where you can see it more. I will skip this one because it's, again, very similar as our previous images, where when you draw the anterior line, you notice that there's a step here. So there's a flexion fracture again on this line. The posterior line is still maintained, and your spinal lamina line, which is this, is still maintained. There's no step on it. It looks sort of really degenerative with osteophytes and things like that, and that's just how sort of old necks look. And here your spinous process line is also well maintained. Okay. How about this one?
Somebody said C7 spinous process fracture, C2 dislocation.
So it is a spinous process fracture, and that is highlighted here. So this is your C2, 3, 4, 5, 6, 7. Yep, 7 spinous process fracture. So if you draw your lines, this anterior line, I'm happy, is relatively smooth. Posterior line, smooth again. Spinal lamina line, I'm happy with that. Spinous process line. Oh, where's the last one? Here. C2 dislocation. I think perhaps this region here, it was just a bit confusing. This, what you've got here is the oropharynx. You've got soft tissue of your tongue here. This is the edge of your mandible just there. And as long as you can draw, you can identify your C2 vertebra and you can draw a line and it seems like it's in alignment with the rest of the vertebra, I would say it's not dislocated. Right. So this is another CT that got done afterwards, and you can see actually a lot more spinous processes are fractured with a lot of soft tissue swelling and edema as well. Okay. Now, this one, I would just give you a hint and say, pay attention to the lateral and pay attention to the anterior, posterior lines and the facet joints, and then tell me what you think.
So people have said chronic osteoarthritis degeneration.
Yeah.
Spondylolisthesis of C7.
2, 3, 4, 5, 6, 7. Yeah, it's a listhesis. Yeah, but
degeneration of joints.
Yep.
Anterior alignment disrupted at C4. Narrowed disc spaces at C5, C6.
Yeah. Great. So everyone's pointing out all the chronic changes, which is fantastic. But mainly, if you draw your anterior and posterior line here, you can see at the level of C6 is disrupted. Here is your C7 vertebral body. So there is spondylolisthesis, more specifically anterior listhesis of C6 on C7. And if you look at your facet joints as well, you go, yeah, I suppose this is This is congruent, congruent, congruent. Then you come to C6 facet joint, and it's not easy to see, but you can't see that same sort of alignment with C7. And basically what has happened is that to get this degree of anterolesthesis, of one vertebra moving on top of another, you need to have facet joint dislocations. And this is exactly what's happened here. So both of the facet joints has come dislocated. It's allowed the vertebral body to move anteriorly. And basically cause a lot of problems with narrowing of the spinal canal. But well done for picking up all the degenerative change. I'm impressed. Right, last one. I want you to tell me, now we are happy with the alignment, we're happy with the bones, you know, we are happy with the joint spaces. I want you to tell me what looks odd and what do these two neck x-rays have in common?
So someone's just said soft tissue swelling. Pre-vertebral space is widened.
Mm-hmm. Yeah, well done. So what do you think this is? So that's exactly that. You've got soft tissue swelling. So here in the front, you can see that this is at least half, if not almost 100% of the vertebral body width. And here, obviously, it's very, very swollen. You can see the trachea is pushed forwards. What density do you think this is? Compare it to the things around it. What do you think it's similar density to? And once you figure that out, what do you think is going on?
People mentioned air.
Mm-hmm.
Someone said retropharyngeal abscess.
Yes, well done. Ding, ding, ding. So when you see air in soft tissue, unless you know that's an injury and it's surgical emphysema, if someone is presenting like an infection or with raised inflammatory markers and you see gas in the soft tissue, you need to think about abscess and gas forming pathogens, basically. So these are both examples of prevertebral soft tissue swelling. In this case, a retropharyngeal abscess, and in this case, it's just pharyngitis, so swelling of the pharynx. That's causing thickening and edema of the tissues anterior to the vertebra. Well done. And I think that should be all our cases for the C-spine. So there wasn't many cases, but if you just remember alignment, like I said, alignment and soft tissue, those are the two sort of things I think are quite different in a C-spine x-ray. If you can remember those two things, I think you will see and pick up most of C-spine injuries. I think it's wonderful that you guys all saw the degenerative changes as well, because you'll see that by the truckloads. But hopefully you feel a little bit more confident the next time you're faced with the C-spine x-ray. So looking at time, I think we've got enough time to at least go through the shoulder, and then after we finish that, we can decide if we want to continue, or I'm happy to send out the last bit of my presentation as slides so that people can go through them in their own time. Right, so back to trying to look at a different joint. We're going to keep the same structure. We'll go through the anatomy of it, go through the assessment together, and then look at some cases. So in a shoulder x-ray, you can get up to 3 views, most commonly at least 2 views. So you get an AP view, so front on, you get an axial view, and that view is taken like this. You lift your shoulder up, and the view is kind of the x-ray is taken from underneath. It's almost like an armpit view, but obviously that means that the patient needs to be able to abduct their shoulder. So it tells you a lot if someone can have this view taken. And then the last one you get is a Y view or a lateral view. So you're basically seeing the scapula on its side, and you're wanting to make sure that the glenohumeral joint is congruent, basically. Oops, sorry. Right, so really basic anatomy. You've got your humeral head, your glenoid, your acromion clavicle, and then don't forget you've got a coracoid process as well. This little nubbin here that points forward in your joint. I used to find this view very challenging because I didn't know what I was looking at until I saw this. So you can break it up into two separate items, a pincer view, so of your index finger and your thumb, and then obviously a golf ball on a tee. So the golf ball is your humeral head, the tee is your glenoid, and then your pincer grip is going to be your acromion. Acromion is much bigger, and your thumb is your nubbin, basically. So acromion is your index finger here, and your thumb is the coracoid. And like I said, this is your Y view. You're seeing the scapula on its side. You're going to have your acromion coming through like this, your coracoid in the front. So acromion is always posterior, coracoid is anterior. And then they all kind of come to a midpoint where the glenoid is, and you basically want to make sure that your humeral head is bang on in the middle of the Y. And that's our anatomy. Okay, so we are going to start using ABC2S again. With A, we're checking for alignment, and mainly alignment of joints. In the shoulder, there's only really two joints. You've got your glenohumeral joint, and you've got your acromioclavicular joint. With the glenohumeral joint, you want to make sure you can see this kind of overlap, like the middle of a Venn diagram. And as long as you have this overlap, you can be quite happy with its congruence. With the acromioclavicular joint, you want to make sure that the bottom of the acromion here is in line with the bottom of the clavicle. If that's the case, it's in line, hunky-dory, move on. When you're looking at alignment with these views, you're mainly looking at the glenohumeral joint alignment, because acromioclavicular joint alignment will be more obvious on the AP view. So this just highlights how your ball is on your T and how this humeral head is right in the middle of the Y. Like so. Then we can move on to look at the bones. Again, you're tracing the cortex, you're looking at the trabecular pattern, and that's quite self-explanatory. Just make sure you trace every single bone, make sure you're happy with the cortex, but don't forget the scapula. So the scapula is a huge area of bone, and half of it, if not most of it, sits behind your thorax. So make sure you just look at it. You can't be blamed for missing really subtle fractures, but if there's something quite obvious and you've not looked for it, then it'd be a shame. Then once you're happy with B, you can move on to C, and you're looking at the same joints as before, but assessing their joint spaces. So it's really this space here between your acromioclavicular joint. As long as it's in line and the space isn't too widened, then you'd be happy. There are specific numbers, but I wouldn't bother memorizing those. I would just look them up if you are ever concerned. And then with the glenohumeral joint, so you're not really looking at this joint space here, you're actually looking at this space here, which is known as the subacromial space. Now, if this space is narrowed, very common. You get people with rotator cuff tendinopathy, and you can see in all people, this humeral head just rises up towards the acromion. If it is widened, you need to think about what's filling it. In this case, is it an effusion? Is it a hematoma? Is it a lipoheme arthrosis? That's all the things that you need to be concerned about this joint space widening. And finally, we come back to the two S's. So soft tissue. There's so much soft tissue around the shoulder. I'm sure you can appreciate that already. But as before, we don't only want to focus on the external soft tissue, but we want to look at this region here. So this, I mean, it's not internal, it's your chest wall. So it's this region here. And this can be the first instance of surgical emphysema in the case of chest injury, rib fracture, and things like that. And speaking of rib fractures, you've also got a whole other section of your shoulder x-ray that's included. So make sure you look at your thorax. You just make sure you just look, make sure you're not missing any displaced rib fractures, you're not missing any huge honking lung tumors or a pneumothorax. And that's the main review areas of a shoulder x-ray. And this is just a little fun fact with shoulder dislocations that I just like to put in there because I found it very useful. On an AP radiograph, there are ways you can tell whether or not a shoulder is dislocated anteriorly or posteriorly. And just type in the comments, which one do you think happens more frequently, anterior and posterior, or posterior? And if the posterior, and yeah, anterior or posterior. So basically, if you think about your shoulder, an anterior dislocation has to come forward, but because you've got this coracoid in the way, it has to come underneath it. So if your shoulder's humeral head is dislocated and inferior to your coracoid, then it has to mean that it's come anteriorly. And I can prove this by looking at the Y view or an axial view. Mostly a Y view, and you can see that your humeral head is displaced anteriorly under the coracoid and away from the acromion. Similarly, with a posterior shoulder dislocation, you'll find that it will be more superiorly, whereas before this was more underneath the coracoid and this is kind of nowhere near the coracoid. And it also has this classic shape, which doesn't always happen, but when it does, it's quite nice to see. And it's called a light bulb humerus, or humeral head light bulb shape. And when you do a Y view, you can see the humeral head is displaced posteriorly towards the acromion. So posterior dislocation versus anterior dislocation. And that's it. So that's A, B, C, 2S of the shoulder. I'm just gonna leave this here for a bit. So if you wanted to just refresh your mind before we go into some cases. Right, okay. So let's go with our first one. What do you think is going on? And I will give you a hint by saying it has to do with alignment.
So someone's mentioned AC disruption or AC luxation, scapular dislocation.
Yeah, so the first few answers were what I was looking for. So you can see here your AC joint is disrupted or dislocated. Move this, yeah, so you've got an AC joint dislocation. With the scapula, I think it's actually quite difficult to dislocate your scapula, if you know what I mean, because it's very much attached to all the muscles on your back. It's more likely that you're going to dislocate something that's joining onto the scapula, for example, the humerus or the AC joint itself. Sometimes you can have disruptions of tendinous attachment to the coracoid as well. But most of the time, I think the scapula does stay in place. It's held down by a lot of muscle. But good go, right? Next. Now, this one has to do with our bones.
People's mentioned humerus head fracture.
Hmm?
Humeral head fracture. That's the, what else? Someone said anterior shoulder dislocation, greater tubercle fracture.
Hmm?
The majority of them said humerus head fracture.
Great. So you're all right. It is a fracture of the proximal humerus, so to speak, but humeral head really just means here, you know, the articular surface, the smooth bit. This is the greater tuberosity. So whoever said greater tuberosity fracture, well done. So here, if you trace the cortex, you notice there's a bit of a, well, not so much a step in this case, but definitely a lucent line. And you can see the fracture here. So this isn't a dislocation, but good go, because you can see you've got that nice overlap between the glenoid and your humeral head. And if you look at this lateral view, which is the Y view, your humeral head is right in the middle of the glenoid. So this is your humeral head. It needs to be very much displaced before you call it a dislocation. Next. This one, again, bones. And I'd be impressed if if you get this, it means you've paid attention, basically.
Someone said fracture of the scapula.
Mm-hmm.
Fracture of the border of the scapula.
Yeah.
Fracture of the body of the scapula.
Yep. All very, very good answers. So that's exactly right. What you've got here is a fracture that appears to extend from, I suppose, the glenoid through the body, and you can see it here on the Y view. And this is a perfect example of how a joint is in the glenohumeral joint is not dislocated, because you can still see the Y is here. So the center of the Y is here, and the glenohumeral joint, or the head, is still in the middle of the Y. So this is not a dislocated shoulder, but there is a fracture through the body of the scapula. Well done. And feel free to type in the box as well why you need to pick up scapular fractures. Why are they so concerning, and why are they important while we think about the next case?
So people mentioning anterior shoulder dislocation.
Yeah, great, which means we all get it now. It's definitely not incongruent, so we know it's a dislocation, and then now we have to figure out if it's anterior or posterior. and it's underneath the coracoid, which means it's anterior. And here this proves that. You can see your Y of the scapula here. This is the middle of the Y, and your humeral head is all the way over here, underneath the coracoid. Well done. Anterior shoulder dislocation. Now what about this one?
Posterior dislocation. Someone said light bulb sign.
Mm-hmm. Yeah, exactly. So this is another example of dislocations. And the more, I don't know if anyone mentioned, but the more common form of dislocation is an anterior dislocation. It's very, very difficult to push against all the back muscle that you've got on your shoulder and dislocate posteriorly. The only instances where you see this, and you commonly hear people say, is if someone has a seizure and all the muscles are tensing up. That's on one of the occasions where a posterior dislocation can occur, because of the power of the muscles gripping and tensing up all at once can cause that. Otherwise, it's always an anterior dislocation, almost always. Right. So what about this? So there's two findings here, I will say that. One has to do with the bones, and one has to do with our C of our assessment, the joint space.
So someone said fracture of the head of the humerus.
Mm-hmm.
Anterior dislocation.
Mm-hmm.
Fracture of the anatomical neck of the humerus.
Yep. That's great. So you're right. That's a fracture of the head of humerus, anatomical neck. It looks like a dislocation, I will give you that. It kind of is. It is subluxed. So when it's not completely dislocated, we call it subluxed. What do you think of this region here?
So people mention blood swelling, swelling of the soft tissue, air.
Yeah, it could be air. That's
air
a very
fluid
good
level.
Mm-hmm. So it does look like air, because it's definitely less dense than soft tissue, isn't it? But in this case, it isn't air. This is fat. So this is a lipoheme arthrosis. Is when you've got fracture of the bone, and all the fatty marrow that sits in your bone leaks out, I suppose. And as the blood leaks out and the fat leaks out, it forms a definite sort of fat fluid level, so to speak. And even if this wasn't fractured and you see a sign like this, you know something's happened and they need further imaging. So well done. It's increased joint space due to a traumatic effusion. Increased joint space, sorry. Let's see how many more we have. I think this might be one of the last ones. So I'm just going to start by telling you that A and B are okay. So why don't you focus on the latter bit of your assessment?
So someone said AC joint rupture, posterior dislocation, sublux AC.
Yep, so there is a subluxed AC. It's not fully ruptured, but it's I will give you that it does look subluxed. No, it's not that. That's not the main thing though.
Someone also said clavicular fracture.
Oh, you here? Yeah, that unfortunately is it's the irregular surface of the underneath of the clavicle. I know that's not very helpful, but that's not fractured. You're getting warmer though. You were looking here, then you're looking here. You're getting warmer. Keep going.
Someone said sternoclavicular dislocation. Some more clavicular fractures coming in.
Mm-hmm. It's the last one, so it's always going to be a bit trickier, but important nonetheless.
Someone said clavicle. The clavicle's in the wrong location, sorry. Acromial fracture. Rib.
So if you're talking about this here, that's just the irregular shape of the acromion. Sorry. No. What do you think about the chest? Someone said rib. Okay.
Oh, someone said pneumothorax.
Yeah, exactly. Well done. I realize this might be slightly delayed, but well done. This is a pneumothorax. And I've drawn that blue line over there to show you you've got lung markings down here, but a distinct lack of lung markings here. So what you can get sometimes is, someone falling over and the shoulder kind of hurts, but they've also got sort of chest pain. And they might have a rib fracture that you've not seen, but you can most definitely see a pneumothorax. So this is a pneumothorax seen on a shoulder x-ray, and that is more common than you think. So always make sure you're properly looking at the thorax, not just giving it a glance as well when you're happy with the rest of the shoulder. And that is the end of our shoulder cases. Thank you very much for participating. I realize that it is almost 9 o'clock now. I do have another section, but I think because of the delay, we've obviously not had as much time as we'd like. So I'm happy to keep going, but obviously I appreciate that this is your evening. So if people want, I can also condense everything down and make sure that you get a like a brief slide copy of the ankle bit as well. I'm not sure how we can get a consensus, or I suppose people, yeah. I will hand it back to Wendy and the team to see what we should do. I'll just stop sharing for a moment.
I think people are happy to continue. There's general consensus on the chat boxes. People are happy to keep continuing.
Okay, right. Thanks everyone for sticking with me. There's only one section left, and if you found it useful, then great, I will keep going. Let me make some amendments so that we can make the quiz bit a little bit faster. So what I'll do is I'll try and show you each film for about 30 to 40 seconds and then move on, and you can write down you can obviously keep commenting in the comment box, and sorry Wendy, you've got the tough job of then reading it out accordingly. All right, just give me 2 seconds, I'm almost done. All right, I'm back. Let me just share my screen again. Can you see this?
Yeah.
Okay, fab. Right, thanks everyone. Let's go through this last bit and then we can let everyone go home and enjoy their evening. So, ankle. Let's go through the anatomy. So you only get 2 views of the ankle. You get an AP view and a lateral view. And I would say they're equally important in this case. So with regards to anatomy, you only really have one joint in the ankle. Yes, you've got a syndesmosis here, which can rupture, but I would say that's more of a cartilaginous joint as opposed to this joint here. So you've got your fibula, tibia, and your talus, also known as the lateral malleolus, medial malleolus. And this is your main joint space. On the lateral view, again, you can see your ankle joint space here. And your medial and lateral malleoli are kind of overlapping each other. So the shorter one is your medial malleolus, and the longer one you can see in the back is your lateral malleolus. Bearing in mind, this is a perfect lateral of an ankle. Sometimes if people are in pain, you can't get this perfect lateral. So you always have to think about that when you're looking for your malleoli. So, sorry. One of the other slightly trickier things with the ankle is obviously there's a lot of normal variants, and they come in the form of little bones that just like to sit in places and mimic fractures. So this here is a very common place called the os trigonum. You can get little bones underneath your fibula, underneath the tibia here as well. So if you ever see fractures in this region, or you see little bones in this region, I would suggest you just Google up quick common accessory ossicles for the ankle and then cross-reference them. I would say if something looks very round and has good borders, very well corticated, then it's likely to be something chronic. It could have been a fracture a long time ago, which is just then, you know, rounded itself off, but it's not acute. Right, so you can tell I've skipped A in our assessment because there's only one joint, and if that joint is malaligned, you would know about it. So we're going to move straight on to B. And like we talked about, we've got a few malleoli. You've got your medial and your lateral, but you've also got a posterior malleolus, and this is the thing. This is the malleolus that you can only assess on your lateral view. And one of the things I will highlight is that you've got a another bone that's often commonly seen in the ankle. So when you do a lateral view of the ankle, like in this case, you can sometimes see your base of fifth here. So when people have ankle injuries, when they invert their ankle, it's a very common thing to fracture at the same time. So the ankle might look fine, but you might have a fractured base of fifth metatarsal. And your posterior malleolus, to highlight that, it's this posterior bit. It's not as pointy, but if you see a fleck of bone in this region and someone's had injury to it, then you have to be suspicious for a posterior malleolar fracture. Often better seen on CT, so any little fleck of bone, be suspicious and sort of order more investigations. And if you can't see anything on B, you're going to move on to C. And like I said before, you only have one real joint in the ankle, and it's the ankle mortise. This here, this lovely dark line is your ankle joint, also known as the ankle mortise. Now, it's very uncommon to get narrowing of your ankle joint because it's a very uncommon site to have osteoarthritis. So in this case, if you have narrowing of one side and widening of another, then obviously that's quite concerning. You want to make sure it's nice and clean, so you can only see, well, sometimes you can see some of the distal tibia through it, but if you look at this line here, this is the anterior joint, or the anterior joint line. The width of the joint space is equal throughout, and if that's the case, you can't see any flecks of bone in it, then hunky-dory, moving on. Which means we can move on to soft tissue swelling and then special review areas. So these are some examples of the ligamentous complexes that follow, that are in your ankle. You've got one here, which is the syndesmosis that I've mentioned before. You've got a lateral complex and a medial complex. Oftentimes when people have inversion, eversion injuries, and they don't have a fracture, it's because these ligaments have gone. The reason why you have a fracture is sometimes the ligaments have held onto that piece of bone, you've stressed it, and that bone is fractured off. But if the bone doesn't go, then something else has to go, so then the ligaments will rupture or tear. And this is the case where you can see quite severe soft tissue swelling, to give you an indication of that. Now, a special review area in the ankle isn't actually in the film itself. It's more of a concept, the polo ring concept. Now, I'm sure you've all been told this in medical school or in uni. A polo ring doesn't break in one place only, it often breaks in two places. And your tibia and fibula are connected at the distal tibiofibular joint and the proximal tibiofibular joint. Kind of like a ring, a really elongated ring. So if you have a really severe injury below, you have to have a high suspicion that something is going to be disrupted up here. So if you see a really severe unstable injury, multiple fractures involving your ankle, it is always a good practice to get a view of the proximal tibia and fibula and up to the knee as well. And this is an example of an eponymous fracture called the Mason nerve fracture, where you've got an unstable distal tibiofibular fracture. It's not very well visualized in this image, often with sort of talar dome shift or widening of your ankle mortise, accompanied with a proximal fibular neck fracture. Yeah, don't worry if you can't remember this, but it's just to highlight that you've got something horrible down here. Make sure you check up there as well. And that's it. So it's much easier the ankle. And now that we're happy with the ABC2S method, what we're going to do is run through our last batch of cases. So I am going to start a timer. And then show you the first case. So I'll leave this on for a while. And we'll look at our next case.
So people mention medial malleolus, avulsion of the medial malleolus, tibial fracture.
I think that's right, but I can't see right now. So we'll go through all the answers at the end, if that's okay, Wendy. When I can actually that's all right. It's good that people are putting their answers through. And then we'll look at the next one. I will say this one is very subtle, and think about your special review areas. Not special review areas, the extra bones you can see in an ankle. And then the next case. Again, this one is quite a subtle fracture, but very important to pick up. Make sure you're looking at your joint spaces very carefully. And then this one. So this one, there are about 3 things that's going on. try and move on. That's it. That's the end of the ankle cases. So I'm not sure how we should do this. I'm happy to just present the answers, or if Wendy can see anything, any interesting answers coming through, then feel free to let me know or pipe in, and I can explain why something is and why something isn't. If that's the case. Okay, but we can go through the first one then. So this first, well, this might not have been the first one, but this might have been the second one, apologies. I think the first one someone mentioned was a medial malleolar fracture, which is correct. Let me just... Let me just find it again. This one here. Oops. Yeah, so this is a medial malleolar fracture. Well done, good pickup. So here you can see a little fleck of bone, and you know it's a fracture. Well, it'll probably come with a bit of history. There's a lot of soft tissue swelling in this region, and this doesn't look like a well rounded chronic piece of bone. Basically, it's angulated. You can see there's a fuzzy border from where it just came off, so it makes you think this is a fracture, and that's right. So this is the second fracture, which I've got in our answer section, which is a lateral malleolar fracture. It's a spiral fracture. I'm not sure if you can tell, it's kind of coming around like a spiral. And this is a very common method of fracturing your fibula, distal fibula. And you can see it extends all the way above the ankle joint and above the syndesmosis as well. If anyone's interested, this is called a Weber C-type fracture, and a Weber classification is for ankle fractures. Depending on where they are, it tells you how stable or unstable the fracture is. The next one that we have is quite subtle, and apologies I didn't find a better film for this, but this is where it's important to assess the other bones that you can see, not just your sort of fibula and tibia. This is a base of fifth metatarsal fracture, and here I tried to zoom it up, and this lucent line you can see here is a fracture of the base of fifth metatarsal. I think if you ever see something like this and you're suspicious for a fracture, it would be fine to request a foot view, because a foot view will have oblique views that allows you to assess that bone much better. And if it's normal, it's normal, you're happy, you can send the patient home. But until you do that, it's very difficult to be 100% sure. This is our next case. So again, this is a very subtle fracture, but if you picked it up, well done. And that's what I'm trying to illustrate about, with regards to looking at the joint space. So if you're looking through this ankle mortise, you'll notice, hold on, what is this? What is this little fleck here? And this is actually a osteochondral fracture. So really what's happened is the top of the cartilage surface has been fractured off, hence osteochondral. And it's a very important fracture not to miss, because someone can have quite debilitating degenerative change in their ankle if this is allowed to just float about, cause inflammation. And obviously you're losing a bit of cartilage there, which is going to impact the articulation and the sort of axial loading of that joint. You can actually also see on the lateral view, I'm going to zoom it up here, and that little flake is that there. It is a bit more difficult to assess it. That's why it's important that you really look at both your ankle mortise views. So it's very difficult to be 100% sure based on this one, but here you can tell that it's definitely fractured. Next one, So I said there were 3 things you can mention. Obviously 2 of them is going to be the fractures. So you've got a displaced spiral fracture of your distal fibula. You've got an avulsion of your medial malleolus. And this is a good example of the case where the ligaments seem to have stayed intact relatively well, but because they're so strong, they've pulled off a piece of bone. And that's called an avulsion fracture. The other thing that we have to notice in this case is that the ankle mortise is disrupted. So very difficult to judge whether or not the joint space is narrowed here, but you can definitely tell it's widened over here. So that lovely little even joint space that you can see here is gone here. And this is a very, very unstable fracture. They often put this very quickly in a cast and then go and fix it intraoperatively. So it'd be very impressive if you could diagnose all these three things and say it on the call to your ortho-reg, so they know exactly what's happened and exactly what they need to do. And that's it. That's the end of the ankle trauma section. It's much easier. And I think the 2 things I want you to take away is ankle mortise and base of 5th metatarsal. Make sure you remember to look at those 2 things. Yeah, so I think that's the end of the talk. Thank you very much for staying till almost 9:30. If you have any questions, I'd be happy to answer them either on my email, or if you want to drop them in a chat box now. I'm sure Wendy won't mind reading them out. But in the meantime, if you've enjoyed yourself, thank you very much for staying and listening. We would really appreciate if you could scan the QR code and fill in a feedback form. Good and bad feedback is all greatly appreciated for us. So thank you very much. I will stay on here for a while longer in case there are any questions. Otherwise, enjoy your evening.
There's no questions so far. Just lots of people thanking you. It was a great lecture. And I think people want more teaching as well in the future, more CT scans as well.
That's good to know. Well, thank you for bearing with me. I know we had a few technical issues, but I really do appreciate it. Yeah, that's great. If people are keen, we could always work through very specific regions or specific CT scans, things that you can assess by yourself in clinical practice.